So good afternoon, dear friends, dear colleague. I'm really glad and proud to be the moderator of this global symposium organized by Straumann. And we will have 2 hours together, and the program is amazing. We have 4 speakers that will discuss about hot topic in periodontal and implant regeneration. But we will have lecture and discussion. So the Q&A is open for you, and please feel free to make all your questions, because the idea of this webinar is to have a close interaction between us, the speakers, and the public. And we will start with the decision-making tree for Flapless periodontal treatment with Dr. Kaspar Wolfert. Then we will discuss with Dr. Robert Miller the decision-making tree for extraction socket management. And then the decision-making tree for gap management in immediate protocols. And at the end, last but not least, we will discuss about the decision-making process in the treatment of peri-implantitis. So as you can see, we have this pathway that will guide us through periodontal and implant regeneration. We will start with Dr. Kaspar Wolfert, that received his dental degree at the University of Gothenburg. Then he moved to the University of Minnesota, and he obtained his Master of Science in Dentistry. And now he moves back again in Oslo. He did a lot of researches. He has more than 20 papers published in peer-reviewed journal, and he is strong partner of Straumann, and he will share with us his knowledge regarding the decision-making tree for flapless periodontal treatment. So I think that this is time for Dr. Kaspar to have the stage, and I will turn off my microphone and my camera, and I will let you the stage.
Dear colleagues, a professional and well undertaken non-surgical treatment phase is of significant importance for the outcome of periodontal treatment. Let's start by quoting Driscoll co-workers in a publication from 2001 stating that non-surgical periodontal therapy is one of the cornerstones in the treatment of periodontitis and the first recommended approach to the control of periodontal infections. So non-surgical treatment is truly crucial to accomplish a good outcome of your treatments. I would like to spend the next 20 minutes discussing and presenting to you some of my knowledge within this field, and hoping to inspire you, and also hoping to potentially intrigue you with what I'm doing in my clinical practice. Now, as you of course are certainly aware of, non-surgical therapy causes less mobility than surgery, to the benefit of our patients. Now, it's also, of course, certainly less invasive, with less risk for gingival recessions in the aesthetic zone. Again, with less damage to root surfaces and tissues, again, to the benefit of our patients. It may also be cost-effective if performed on the right indication and if performed well. We work hard in our clinic to develop our technical skills when it comes to scaling and root planning. I find that extremely useful, both from the perspective of pure non-surgical treatment, but certainly also for the surgical treatment phase. You need to have optimal technical skills in your hands when it comes to non-surgical therapy, using the right instrument and working on the right indication. Now, access is certainly limited. That's one of the drawbacks with non-surgical therapy, and we can't do any visual inspection of the roots. Now, the regenerative potential of the therapy is certainly also limited. So these are some of the drawbacks, but I mean that the benefits, of course, are weighing up the drawbacks. A thorough clinical examination is of vast importance for any type of periodontal treatment, but of course also for other dental therapies. Remember to spend a sufficient amount of time, plan your cases. I used up to an hour for all my baseline examinations to evaluate my patients. Clinical examination containing both probing pocket depth, clinical attachment levels, of course registering furcations, mobility, bleeding or probing, gingival index, and obviously also vitality if any suspected endodontic lesions. Now, you also include our subclinical parameters such as radiograph, but potentially also microbiological testing if found useful. So use sufficient amount of time on your clinical examination prior to classifying your patients. Use obviously the EFPAP classification system developed by this fantastic group of scientists. It's an extremely useful system. So if you haven't read the system, the publications behind it, 317 papers or pages with important and useful information for your clinical practice. So spend the time reading those publications. Highly appreciated that this work has been done. Now, as you're certainly also aware of, the scientific databases, the publications behind how we work is extremely extensive when it comes to periodontal disease treatment. Now, this is a publication by Suvan and co-workers from 2019. They conclude, which is of course useful information, that non-surgical periodontal therapy by mechanical subgingival instrumentation is an efficacious means to achieve infection control in periodontitis patients. They also conclude that average pocket depth reduction 6 to 8 months after healing will be 1.4 millimeter. So that, of course, is something that you can use when you do your case selection, what treatments to be undertaken. Now, this is my way of doing case selection. This is my decision-making tree for Flapless periodontal treatment, which again lays the ground for the cases that I'll show you later. It's obviously important with your clinical examination, as I already stated. Optimal plaque control is crucial. So please remember that prior to doing any advanced periodontal treatment, any active periodontal therapy, you need to have your patient under on a regime which leads to optimal plaque control. Work hard with that. If you don't get your patients to accept that, continue to work on it until you have your plaque levels below a certain threshold. We used the threshold 20% in Oslo. Now we of course check the vitality of the teeth under any suspected lesions. Will be treated prior to initiating our active therapy. So has the patient been treated non-surgically recently? If no, we of course on those new patients perform a full mouth scaling and root planning phase with a re-evaluation 4 to 6 weeks after therapy, and if we have pockets below 5 millimeters throughout the dentition, we simply put the patients in a maintenance phase, which is again extremely important for the long-term positive results. 3 to 6 month regime with maintenance by one of our skilled dental hygienists. Now, patients with remaining pockets 5 millimeters or deeper are certainly treated surgically, at least probably treated with surgery. Periodontal surgery, we reevaluate our patients again, and again keep them on a strict maintenance regime. Now, patients that has been treated with surgery recently, you may not want to include them in a new surgery. That might be difficult. So if they haven't been treated surgically, you may suggest surgery, or you may decide to do surgery also on those patients, followed by patients that has been treated surgically, has had surgery undertaken. Then you may choose to do a more advanced non-surgical treatment strategy, potentially with chemical adjuncts such as Emdogain, to avoid performing further surgery. That also goes for patients with just a few localized periodontal pockets. They may also be included in a more advanced non-surgical treatment phase. I'll come back to that later in my lecture. Prior to, again, maintenance. Maintenance is certainly the buzzword, crucial to a long-term positive result. I'll focus the rest of my lecture on localized non-surgical therapy with both with and without chemical adjuncts. Now, this is one of my old patients treated close to 20 years ago, and as you can see, she has extensive inflammation throughout the dentition, marginally and papillary gingivitis, erythema, edema, and again, extensive bone loss throughout the dentition. As young as I was, I said to myself, this case will be very difficult to treat. I don't suspect that I will be able to, at least don't expect that I'll be able to avoid surgery. Maybe this is an implant case. Maybe I'm going to extract all her teeth. That was my early thoughts prior to starting the treatment. I'm showing you this case just to make you aware of what you can actually accomplish with advanced non-surgical periodontal treatment. So using good technical skills and extensive amount of time. Now this patient, this is what it looks like. She has pocket depths 2 to 10 millimeters in depth, clinical attachment levels of 1 to 9 millimeters. She has degree 2 furcations at all her molars, and she has generalized edema and erythema with swelling and redness. So she's classified as a stage 4 grade C patient. As you can see here, this is after we have undertaken our treatment. We extracted her wisdom teeth. We tried to get her in better diabetic control, working hard with her physician on that. And we performed 4 quadrants on scaling and root planning. And this is what she looks like already after 6 weeks. I can see a significant reduction in infections and a significant reduction in inflammation. And you can almost see how much better she has gotten. She has now, after 12 months, minimal signs of inflammation, pocket depth 2 to 7 millimeters. She had some remaining pockets, certainly, but she was not interested in having surgery undertaken. She refused surgery. At that time point, to my regret, since I was a young periodontist that had a plan to include her in as one of my early cases with surgery. Now, she is seen by a dental hygienist every 3 months, and after 9 years, my dental hygienist at University of Minnesota, our dental hygienist over there, she has her come back, certainly on every 3 months, but I'm probing her every year, doing an evaluation every year. And after 9 years, this is what it looks like. She has now 1 to 5 millimeter pockets and only minimal signs of inflammation. So surgery is no longer indicated. Again, just to show you what you actually can accomplish with such advanced non-surgical therapy. But that I would like to show you a relatively novel instrument for non-surgical therapy. This is Labrida BioClean, which is my invention for less invasive strategy for treatment of periodontal disease and for maintenance of teeth and implant. So the Labrida BioClean is an instrument based on chitosan. So the blue fibrous disease is made of chitosan. The reason for that is that the idea was to make a safe instrument with resorbable chitosan fibers. You don't leave any remnants of chitosan after you treat you perform your treatment. Now it's gentle, which means no damage to teeth and implants. So a gentle instrument for treatment of teeth and implant, and it's scientifically documented. We now have publication in the face of we now have scientific documentations in the face for publication, also for treatment for periodontal treatment of teeth, and certainly also for implants. So this is one patient, young lady. In this case, it's an implant. As you can see, she has some deep pockets, and she is treated with Labrida BioClean. You can see the inflammation, and those are implants. You only got mucositis, and you can see the way we work with the instrument using an oscillating dental handpiece, and insert the instrument into the pocket. The blue working end containing chitosan fibers, which grants for a gentle treatment in this patient of an implant. So by that, I would like to show you novel way of treatment, of non-surgical treatment, which I myself have developed, combining Labrida BioClean with Prefiel and Emdogain. So non-surgical treatment with a chemical, with an adjunct chemical in this method, Prefiel and Emdogain. Now, why Emdogain? Why is it even interesting to consider Emdogain? Well, in the early phases of Emdogain therapy, which of course, as you all know, is made for or developed for surgical regenerative treatment. It was discussed that it may also have some advantages for non-surgical therapy. This is Lyngstås and co-workers demonstrating that Emdogain may inhibit growth of epithelial cells. Now Wenström and Linde performed a clinical study showing improved early soft tissue healing when combining Emdogain with non-surgical treatment. Now Mobelli and co-workers in 2005 performed a randomized clinical trial showing that sites treated non-surgically with Emdogain combined with antibiotics demonstrated better cal gain. And this is an interesting publication by Graziani and co-workers in 2019. This is one of the cases, compliments of Dr. Graziani. As you can see, 7 millimeter deep pocket on tooth number 1. And after scaling and root planning, what Graziani is doing and co-workers, they are comparing scaling and root planning with or without Emdogain. So non-surgical treatment with chemical adjunct chemical. Now what they're doing here is opening the pocket, injecting Emdogain, and this is the result after 3 months. You can see the reduction from 7 millimeter down to 3 millimeter pockets. Obviously a nice result. What they conclude is that Emdogain application lead to greater pocket depth reduction and clinical attachment level gain in sites with pocket depth 6 millimeters or deeper. Now, they also conclude that a higher number of cases with no residual pocket depth 6 millimeters or deeper at 3 months were seen in the cases treated with the combination of scaling, root planning, and Emdogain. So that I find is a very intriguing result released. This is one of my patients where I combine Emdogain with Labrida BioClean. So this is my clinical method for such patient. This young lady, I had undergone treatment for about 4 years with some remaining pockets that I really couldn't get to heal up. That I really couldn't find a good way of treating. So a little bit frustrating, but I decided to at least try combining Labrida with the Emdogain, Labrida BioClean with Emdogain. Now you can see the pocket, 6 millimeter deep pockets, close to 7 millimeters. You can see the inflammatory defect, and this is scaling and root planning, localized scaling and root planning, removal of granulation tissue, which again had been done repeatedly before. And you can see how I use Prefiel with the Labrida BioClean as a carrier, which is an easy way of applying Emdogain. So applying Prefiel. So what I'm doing here is injecting EDTA Prefiel in the pockets, and I'm using my Labila BioClean to do a mechanical debridement of the brush, a gentle method of debridement. Now you can see that I insert a gauze to open the pocket. I inject Emdogain, and this is the result after 6 months, from 7 millimeter with bleeding and probing down to 3 millimeter with no bleeding or probing. One specific case, I would like to show you my next case. I've now done a number of these cases with some interesting results. This is a lady. I want you to focus on tooth number 1-1. As you can see here, she has an 8 millimeter pocket with bleeding. Again, she had been treated repeatedly before, so I wanted to try something new to see if I could get the grasp on those deep pockets and see if I could help her. Again, scaling and root planning and Prefiel, and using the Labila BioClean for mechanical cleaning. Again, she had been treated repeatedly with scaling and root planning with no positive results. So we are trying to combine a mechanical debridement with Emdogain. So Prefiel, now inserting a gauze into the pocket to open the pocket, and we place the Emdogain. And this is the result after 6 months. You can see baseline 8 millimeter pocket with bleeding and probing, and after 6 months, we have a 3 millimeter pocket with very limited bleeding or probing. So again, a positive result. I hope that will intrigue you. Now, by that, my conclusions of this short lecture: a well-performed non-surgical periodontal therapy combined with optimal measures of infection control is the basis for an efficient treatment of periodontitis. Now, combining non-surgical therapy with chemical adjuncts such as local antibiotics, Prefiel, and Emdogain may be beneficial. So, infection control and professional maintenance after active periodontal treatment, always remember that, is mandatory for a long-term positive result. Thank you very much for attending my lecture, and I hope I inspired you and intrigued you.
Thank you very much, Dr. Wolfhard, for your amazing presentation. I think that it gave us a lot of insight into this non-surgical treatment to periodontitis, and we have a lot of questions, meaning that there is a lot of interest in this topic. And the first question is related to the vitality test. How important is the vitality test in the outcome of scaling and root planning, according to your experience?
And that's a very important, of course, question issue. I mean, I ascertain, of course, that we don't have any endodontic problems with our teeth. You know, if you start a root planning phase, you expect some good results, and you want to make sure that you don't have any other etiological factors which may be related to apical pathology. So of course you don't proceed and vitality test all your teeth, but if you have any suspected lesions, you want to certain that you perform your endo before, wait 6 months or so, then you can start your scaling and root plan. Again, if the lesion is related, if it's an endo-perio lesion, you don't want to remove that periodontal ligament, remaining periodontal ligament. It may just be an endo lesion causing the problem. So ascertain that your teeth are vital, potentially perform a root canal treatment as needed. Yeah, that's basically it.
And I think that this question is some way related to the second one, that is regarding your decision about when you decide if a tooth is hopeless and irrational to treat. Is that, for example, endoperio lesion something that guide you in this decision toward an hopeless tooth, or for you an hopeless tooth is something different?
Of course, we can go back to our old publications by McGuire, for example, and follow all those old publications looking into prognosis of teeth. But I mean, also it's related to the clinical evaluation, the clinical perspective, what you feel that you can accomplish. And sometimes I feel that when it comes to endodontic lesions, clinicians get so, shall we call it, afraid by what they see. They see an advanced endodontic lesion, and they say to themselves that tooth is definitely lost. I think we can accomplish more than we believe when it comes to endodontic treatment. Of course, working with a good endodontist. So sometimes I feel that we give up a little bit too early. But after having worked many years, I think you have quite a good feel of what teeth you can relate. Combining endodont, for example, molars, combining endodontic lesions with grade 3 furcations and such, then those teeth are lost. So I think it's quite difficult to say on a general perspective. Just to make a list here now on what should be extracted. Of course, fractures is one thing. What else?
I totally agree with you regarding the idea that when we have to face an endoperio lesion, the decision making, since today we are discussing about decision making tree, it's probably to treat the endodontic portion of the defect with the endodontic treatment, wait the resolution of the apical reaction, and then treat the periodontal side of the defect, starting with the non-surgical treatment. So I think that the message that the audience should take home is that and endoperio lesion are not the indication for tooth extraction, I think.
Exactly. Yeah.
Maybe I was thinking about furcation involvement, because I think that grade 3 furcation involvement, especially at the level of the molar, is something that nowadays push has toward tooth extraction and implant placement. Even if sometimes, and we have a lot of paper in literature told us that even teeth with a furcation involvement can be maintained over time with a street recall maintenance program. So I think that probably the most hot topics when we speak about tooth irrational to treat is related to furcation involvement. Do you agree with me?
I completely agree. But the longer you work, the more you start to realize how long you can actually get and how long you can save those teeth. Also remember, which I find extremely interesting, if you go to the literature, you will know that more than 80% of teeth that are deemed hopeless by us dentists are never extracted, because the patients doesn't want to extract them. So, and then you realize after 5 to 10 years that they are still sitting there and they got grade 3 furcations. And I said that that tooth should maybe have been extracted. Now it's still there. So I think the longer you work and the more clinical experience you get, I'm not so inclined extracting teeth with the grade 3 furcations and longer, tunnellations, doing funneling, radixectomies. What else? Again, you always need to, which I'm trying to really, implement both in my practice and telling my attendees in my lectures, always consider the alternative. If you, for example, have, massive amount of bone loss, upper molar, grade 3 furcations, and so on, and if you save that tooth, you may avoid ending up in a situation where you have to do a sinus lift, where you have to do an extremely extensive, costly treatment for the patient. And you may end up in a situation,
because also patient perspective is something that we should always take into consideration, which is another important aspect. There are many questions for you, so we don't have the time to answer to all these questions. One of these questions is that in aggressive periodontitis, which is the old way to define periodontitis, but anyway, you understand the meaning, it is favorable to use endogen, and I want to add to this question, is it better to use endogen or it is better to use antibiotics? Because we have plenty of literature on the use of the antibiotics in adjunct to the traditional scaling and root planing. Do you think that the adjunctive use of endogen, it works better than antibiotics?
That's a very interesting question. I don't have a good answer for it, too, admittedly, but you know, interesting question.
On one side, I think that we reduce the risk of antibiotic resistance, because the use of antibiotics is something that nowadays it's a problem.
I can't say that I know of any studies comparing, systemic use of antibiotics versus Emdogain. Again, even no studies comparing localized use of antibiotics versus Emdogain. Of course, that would be an interesting project to look into. I mean, if you can avoid antibiotics, that would be great. Although I have to admit that we use, of course, less and less systemic antibiotics. I don't know how, I don't remember the last case I used antibiotics on. Just this morning, to be honest, I had one case treated back in 2013 with the use of systemic antibiotics with a amazing result. But that's one of the very few cases. Aggressive disease, again, whatever you would call it these days. But you know what I'm saying.
We need to prepare a protocol and to test against antibiotics. So we have something to do in literature. And the last question, because I think that the time is over, is related to the post-surgical regimen that you prescribe after the application of Emdogain after scaling and root planing. There are some specific indication for you, for the patient?
You mean about you mean for maintenance? Or
Let's say in the post-treatment, let's say not post-operative, but in the post-treatment with the Emdogain in surgical therapy. Do you teach the patient not to brush or something?
Well, I have my patients. Of course, I'm certain that I have, excellent plaque control. I had the patient come back after 4 weeks. In those cases, admittedly, I bring them back already after 4 weeks, just a little bit because I'm curious. I find it, of course, important to ascertain that the plaque control is still there. So it's probably not a bad idea to continue doing that. Re-instructing the patients and so on. Again, have the patients come back after 3 months, 6 months, and so on. Of course, I avoid having my dental. This is again important. I avoid having my dental hygienist scale, do subgingival scaling, root planning of those specific sites up to 6 months after therapy. Again, that's important to remember. If you have an external dental hygienist, you want to write a note to your dental hygienist, your referring dental hygienist, that you don't do subgingival scaling, root planning on those specific sites. So quite similar to surgical treatment with Emdogain. Again, plaque control is the most important issue here, I guess. Yeah.
There is one more question that is, have you experienced any bone growth, I mean bone regeneration, with the application in a flapless way of Emdogain?
Bone regeneration, if you see the bone regeneration, yet on my cases, Emdogain.
Yes, if you use it flapless.
I haven't followed my cases. If you look at Wenström and if you look at Mombelli's study, he reports that he see more clinical attachment level gain, but I can't say that I have seen any radiographic signs of bone fill. That would be. I don't know of any histology having been done on the use of Emdogain in a flapless situation, which will be needed to show regeneration. Again, in my cases, those have been followed for such a short time, so we'll have to wait longer to be able to demonstrate, either bone fill or look into other parameters of regeneration. So too short time in my cases so far. But again, the clinical results are quite stunning. Inspiring.
Yes. So thank you very much, because your lecture was really inspiring, and these promising data encouraged me to start to use your approach. And I think that we give also the idea of the need in literature to make some study and to show the scientific efficacy of this novel approach to the treatment of periodontitis. Thank you very much.
Thank you very much. Nice questions. Nice talking with you.
Thank you.
Very good.
So now we have the second speaker of the afternoon. Dr. Robert Miller is with us, and he is going to discuss about the decision-making tree for extraction socket management. So when we decided that tooth is hopeless or irrational to treat, as we just discussed with Dr. Wolfer, we need to extract and we need to manage the socket. So this is what Dr. Miller, that received his dental degree from Boston University and his certificate for advanced graduate studies from Boston again. And he is a well-known international speaker. He is an active member of the Academy of Periodontology and Osseointegration, and he is an ITI fellow. And I think I will let him the stage for his lecture, and I will be back again to answer the question of this really active public that we have today. So thank you, Dr. Miller. The stage is yours.
Greetings, everybody. My name is Dr. Bob Miller. I'm a periodontist down here in South Florida. And before I begin, I just want to say a quick thank you to the people at Straumann for inviting me to this symposium. It truly is an honor and a privilege to be presenting for you today. And I also feel very lucky to be presenting with such a really talented group of clinicians as well. Now you can see from the presentation here that I started off the presentation with a quote, "Getting your ducks in a row." Now what does that mean? That's a sort of an American expression, and getting your ducks in a row really refers to being well prepared or organized for a certain task. Well prepared or organized. And that's really the essence of this presentation. The essence of this presentation is sort of having a mindset or a thought process once you extract a tooth and whether or not you can place an immediate implant or consider a staged approach. Now, when you think about that, that's an important part of a lot of our practices. And I've titled the presentation Innovative Bone Augmentation, and what I'm doing basically is providing you with a decision tree, a thought process, once you extract a tooth and are considering immediate implant placement. And I truly believe that if you can perform this procedure successfully, it truly is a practice differentiator. It separates you from the other clinicians in your community. And the reason I believe that is because patient acceptance is there. Patients would clearly prefer fewer surgeries or simultaneous implant placement. Now, what I'm going to do is I'm going to break this presentation up into a couple of different small parts. The first thing we're going to do is we're going to talk about that need for predictable guided bone regeneration. Clearly, you can't have successful osseointegration or successful implant placement unless you have predictable guided bone regeneration. Then the next part of the presentation, we're going to go through that decision tree, the thought process on whether or not you can place the implant immediately, simultaneously, or you have to consider a staged approach. Then lastly, what I'm going to do is I'm going to talk about the clinical relevance. Okay, I'm going to show you how I'm using this thought process and these concepts successfully in my own personal practice. So hopefully you have something to bring to your office the next day you're in your office practicing, and some thought process in this regard. Now, what I want you to do is I want to kind of go through the presentation first, and at the end of the presentation, we're going to have a Q&A, a question and answer period. So hold your questions for the end of the presentation, and I promise we'll get to each and every one of them. Now, a little bit about me. Like I said, I'm a private practice periodontist. I practice in a place called Plantation, Florida, which is just west of Fort Lauderdale, to give you an idea where I'm at right now. And I'm also on staff at both Boston University, and I work with residents at University of Florida down here in Miami. The main campus is up in North Florida, but I'm down here in South Florida with my residents. Now, one of the things that when I look at my own practice, one of the things that kind of jumps out at me is the fact that when I look at my day in, day out procedures that I perform, yes, I do put a number of dental implants in. But when I really look at what occupies the largest part of my day, the largest part of my day is growing bone, guided bone regeneration. That is truly the largest part of my day. And yes, I do a significant amount of GBR, but I also put a couple of dental implants in. And to be successful with your dental implants, you have to have good quality and quantity of bone. Now, it's also backed up in the literature. Doctors H.P. Weber and Dr. Boozer, in one of their articles a couple of years ago, estimated that it's over 40% of all osseointegrated implants have required some form of GBR as part of the rehabilitation. And again, when I look at my own practice, I almost think that number is actually larger. So I say kind of jokingly, yes, I'm a periodontist, but what do I do most of is GBR. So I almost think of myself as like a GBRologist or something like that. But that's really the truth of the matter. So when we extract a tooth, and there are a number of choices that we have in implant therapy. And the first thing we have to decide is whether we're placing an immediate implant or we're considering a staged approach. In other words, GBR and then extraction, GBR, and then follow up with an implant after hard and soft tissue maturation, or doing the procedure simultaneously. But when I actually look at it in terms of indications, and particularly post-pandemic, or we're actually still in the pandemic, but a lot of my patients have put off dentistry for a year, year and a half, almost 2 years. And so we're seeing an awful lot of root fractures, extensive decay, periodontal disease, trauma, things like that. We're seeing a lot of indications for extraction and immediate implant placement. And if you think about it, again, in terms of patient acceptance, what patient wouldn't prefer to have this done simultaneously versus multiple surgeries? Okay, it's fewer surgeries. It reduces the overall treatment time of the procedures, and also if you think about it in terms of chairside production, the more production that you, or the more dentistry that you can do, if you can do this in a single appointment, the more productive you are in your practice. Okay, so there's a whole host of different reasons that you might want to consider immediate implant placement. But when I kind of like go over, when I evaluate the site, there's a couple of things that kind of jump out at me. One of them is the soft tissue, the quality, the quantity, and the morphology. In other words, you have to have keratinized tissue around your dental implants, no question about it. And sometimes you don't, so you have to consider that staged approach. Bone quality is also extremely important as well. You have to have sufficient bone, and the morphology of the bone, both horizontal and vertically, have to be appropriate for implant placement. And also, if you want to place an implant simultaneously, you have to have the ability to place a stable implant. The implant has to be stable as well as the graft in order for it to be successful. So initial stability is extremely important. But what I consider the most important fact is whether or not the implant is surgically driven, yes, but it has to be prosthetically guided. In other words, the implant has to be in a restoratively appropriate position. If you can't restore the implant appropriately, then you should be considering a staged approach. Or if you can't uh, generate enough bone, regenerate enough bone, then maybe crown and bridge is appropriate. But again, it has to be surgically driven, but it has to be prosthetically guided. Very, very important. Now, there's a number of classifications for extraction sockets, but there's a couple of them that kind of jump at me as being the most appropriate. One of them is by a group in NYU, Elion and others. Dennis Tarnow is part of this, Dr. Fromm, Chu, a number of different people. And what they did was they broke it up into 3 different types of sockets. Okay, if you look at a type 1 socket, okay, you have adequate facial soft tissue, that's intact, as well as an intact buccal plate. So clearly, that's something you would probably consider an immediate placement for, again, if it's restoratively driven. A type 2 socket is you have intact soft tissue, but the buccal plate is somewhat compromised. Okay. Then a type 3 extraction socket, the soft tissue is compromised, meaning you have recession, as well as a compromise of the buccal plate. And that's basically how things have been broken up for many, many years. So looking at a potential site, you have type 1, type 2, type 3. Looking at a type 1 extraction socket where you have intact soft tissue, intact buccal plate, you would consider immediate placement with or without GBR, with or without guided bone regeneration. I'll show you a quick case. So here we have a situation where the upper right central incisor is somewhat compromised. Patient had some trauma, calcified canals. You can see that we had some hypermobility here. But looking at the soft tissue, we have a nice thick gingival biotype. You can also see on the right, you can see a cross section of the CBCT. We have a beautiful, beautiful, thick, intact buccal plate. So in this situation, what are we going to do? We're going to extract the tooth, place our dental implant, hopefully in a restoratively driven position. And in this case, I used a little bit of allograft, a min-D-min combination, packed it into the small gap-type lesion, used a membrane on top of that, and allowed the area to heal. You can see the extraction socket, implant placement immediately post-surgery, and then at the 3-month mark. Here's our final restoration, and again, it came out as good as we can possibly imagine. Why? Because we had a good buccal plate, and we had good, thick, gingival biotype. Here's her 2020 radiograph. Here's her preoperative radiograph, as well as a 1-year post-op. And again, we were able to do this quite nicely. Why? Because we had good, thick, soft tissue, as well as an intact buccal plate. Looking at a type 3 extraction socket, those are typically cases that we're going to consider a staged placement. Now we have choices here. We can extract the tooth and do a simultaneous GBR procedure, which is a possibility, and then we can place a dental implant after maturation, hard and soft tissue maturation, or we can consider a second option, which is an extraction, allowing the soft tissue to heal, and then performing our GBR procedure. And we have a choice here as well. We could either place the implant simultaneously with the GBR, or we can consider immediate implant placement. So we have choices here. Delayed GBR with or without simultaneous implant placement once we've regenerated enough keratinized tissue. So here's what I'm going to do. I'm going to show you a procedure here, a case here, where we performed the staged placement. Here we have an upper right cuspid Clearly, the tooth has some significant problems around it. The tooth had some external root resorption at some point. They performed endodontic therapy, allowed the tooth to probably should have been extracted a while back. But if you look at our CBCT, you can see that we completely lost that buccal plate almost to the apex of the tooth, actually beyond the apex of the tooth. So what we wound up doing here is extracting the tooth, allowing for soft tissue maturation, where you typically wait about 6 to 8 weeks to allow some of that keratinized tissue to sort of regenerate. And in this situation, looking at the extraction socket, we were able to place the simultaneous implant with the GBR. Why? Because again, one of the things we have to look at is the quality and quantity of the bone. Here we had sufficient quality and quantity of bone that we can place it immediately. We can place the implant within what I call the bony socket. We placed our freeze-dried allograft, the Min-D-Min graft, on top of the exposed threads, and we allowed the area to heal for about 3 months. We opened up the area. You can see a good quantity of bone, buccal plate, regenerated that buccal plate really nicely, and you can see our final restoration. Here's our beginning, middle, and our radiograph taken about 2 months ago. And again, looking at the buccal plate, you can see we were able to regenerate that buccal plate really quite nicely. So again, once we had adequate keratinized tissue and we had a situation where we knew that we're going to have adequate keratinized tissue around our dental implant in the final restoration, and I was able to place the implant simultaneously. Why? Because I was able to place the implant again within the bony envelope. Now, looking at a type 2 extraction socket, that was broken up into 3 different types: 3A, 3B, and 3C. This appeared in an article a little while back by Dr. Chu and others at NYU back in 2015. And what they did was they categorized the type 2 defect typically has intact facial or soft tissue, but there's some degree of compromise to that buccal plate. A type 2A actually has a moderate amount of compromise to the buccal plate. Type B has a little bit more compromise, more bone loss, facial bone loss. Type 2C actually has an advanced or a lack of buccal plate. So here's what I'm going to do. I'm going to show you a couple of cases here. This is a case that I did a while back in 2008. This is at the time was a very young woman. She was about 23 or so years old. She had suffered some form of trauma. I think she fell off her bicycle at some point when she was about 14, 15 years old. You can see they had performed some endodontic therapy, but clearly things had gone bad. The tooth had fractured and the tooth was abscessing. She had visited a number of other surgeons prior to me, at least 3 or 4 other surgeons, because she was really afraid of having this tooth removed. Why? Because she was actually afraid that it would not be able to be replaced in an aesthetic fashion using a dental implant. She went to a few other people. She wound up coming to me, and I'm going to show you the sequence here in the thought process. What I did was I opened up the area. You can see we had a big facial dehiscence. We lost an awful lot of that buccal plate, which is not surprising. So I categorized this as a type 2C extraction socket. This is a situation where I really didn't feel comfortable placing a dental implant simultaneously. So what we did here is we used a mineralized freeze-dried bone, because back then that's what all we had back then was mineralized freeze-dried bone. And the reason why I like using freeze-dried bone is it's similar to the patient's own bone. Okay, so from a morphological standpoint. And also I like the resorption time. Okay, in other words, it's about 3 or 4 months that the bone you find good bone turnover, and it also provides an adequate matrix. Okay, to give us a substantial bone regeneration. Now today I'm using a mineralized demineralized combination. I actually Borg and Mealy came out in about 2015, and what they did was they showed us that really there wasn't that much. There was very little, if any, no significant ridge dimensional changes if you went to a combination of either 80-20 or 70-30 of min-demin combination. And the histologic evidence actually showed that when compared when they compared each of the two different bones, there was actually a greater new bone formation using the demineralized freeze-dried bone in combination with the mineralized. And they showed in the article that this was a very, very significant for us. So now we're using a min-demin a combination at this point in our office. So we went ahead, placed our bone. Again, this was 2008, so we used just mineralized freeze-dried bone, placed our barrier membrane, closed over, and re-entered at about 3 months. And at that point, we had a good yield of freeze-dried bone, of regenerated bone. We were able to place our implant at that point. I used a titanium zirconium alloyed implant, a narrow connection, Straumann. We used a bovine bone on top of this to create what I call a root eminence. Okay, and the reason why I choose the bovine bone here is, and the xenograft, is because of resorption time, and it allows the scaffolding to be intact for a little bit longer. And typically, you get yourself what I consider a really nice root eminence, and it's sort of what I like to call the frame around the picture, and providing hopefully a more aesthetic restoration for this patient. We closed over, and then we allowed the area to heal for a good 3.5 months. And then the restorative doctor I was working with fabricated a provisional, and we start training the tissue. And ultimately, we made impressions. He did a custom milled zirconia abutment. This is one of the original Etcon abutments. And he fabricated what I consider a really nice aesthetic restoration. And you can see the final restoration and product. Literally, this is again back in 2008, 2009. Patient was very, very happy. I was very happy because I was really able to regenerate a pretty nice buccal plate here, and I had a lot of confidence that this implant will be successful. Here is her final smile. The patient was ecstatic, as you can well imagine. And again, she didn't have a high smile line, but she still was concerned about her aesthetics. Here's our 2009 X-ray, 2013, and we fast forward a couple more years, our 2018 and our 2021. And again, we were able to really maintain that bone quite nicely, and we still have a very successful and happy patient at this point. So again, we break it up into 2A, 2B, 2C. That was a 2C. I'm going to share with you one final case here. This is this woman is about 58, 59 years old. She's had restorations placed. The tooth number 8, also the upper right central incisor, also had some form of trauma a while back. They tried endodontic therapy. For some reason, they said the canals were calcified. That's what she was told. They placed a post and crown into this, and obviously we had some significant recurrent decay and apical pathology necessitating its extraction. Okay, here's our CBCT. You can see that we have a little thin isthmus of bone, looks like coronal, but apically, after apical surgery, it just didn't really work out for her. And we have what I would call an apical fenestration at this point. So The thought process here was to open up the area, extract the tooth, and you can see once the area is opened up, you can see apically that we have that fenestration that would require some form of GBR. We are able to place our implant again within the bony envelope. Okay, what I mean by the bony envelope is a restoratively driven position, intact apically, and within the confines of the buccal plate. Implants placed, and then we use a freeze-dried bone. This is a min-D-min combination. I pack around the apex of the dental implant, and I place my bone, and then I use the Jason membrane, which is a porcine pericardium membrane that I typically like to suture in place. We close over the area with a horizontal mattress and a couple of simple interrupted sutures, allowed the soft tissue to heal. And you can see some really quite nice soft tissue healing and maturation. This is our implant once it's osseointegrated. And here is once we place a transmucosal healing abutment. This is prior to restoration. And this is the patient's final restoration. And we had a number of things going on our side here. Number one, we had adequate soft tissue. Both the morphology and the quantity was adequate. We also had an intact or so buccal plate, but I was able to place the implant in a restoratively driven position. So again, the patient was really quite happy here, and he wound up, you can see, with a really nice final restoration. You can see that we have what I consider a really nice buccal plate that we're working with at this point, and a very happy patient. Now, the take-home messages here for immediate implant placement is your predictability will increase. Number one, if it's prosthetically guided placement. Number two, if we have adequate keratinized tissue and also the adequate bone, and the implant has to be placed within the bony envelope, and we have to have good initial stability of both the implant and the graft. So with that, I would like to say thank you for your attention. I appreciate, again, the opportunity that Straumann has provided me, and I look forward to hearing from you. So again, thank you very much, and we'll answer some of your questions now.
Thank you, Dr. Miller, for the outstanding presentation. And we received a lot of questions for you. So I will start because we have only 10 minutes to answer so many questions. The first one is regarding the choice of the biomaterial for guided bone regeneration. Do you have a preferred material for guided bone regeneration, and how you to determine what material use and when?
Yeah, that's actually a really good question. I'm going to start off with a short story. When I was a resident, I once went to a GTR, guided tissue regeneration symposium, given at the University of Pennsylvania, given by Dr. Linde and Dr. Stuart Neiman. And I remember him talking about the biomaterials that we used for that they used for GTR back then. And I was a young resident at the time, and I wanted to introduce myself, ask you a quick question. And so I found him in the back of the auditorium, and I went up to him and I said to him, I said, my name is Bob Miller, I'm a resident. And I said, how did you decide to use a millipore filter for a barrier membrane? And he looked at me, he says, Bob, he said, you can cut up pieces of the New York Times and use it as a barrier membrane. And I thought to myself, could you imagine turning to your dental assistant and saying, could you please pass me the sports section? I want to grow bone on the mesial aspect of a molar. Anyway, the truth is my choice is, it has to do with resorption time. And it also has the resorption time of the membranes and also resorption time of the biomaterials. Obviously, for directly against my implant, I want more rapid turnover because I'd like to have greater bone in contact with my fixture body. If I'm trying to develop a root eminence or a horizontal graft, obviously I might change to something that resorbs a little more slowly. Maybe I might use a porcine pericardium membrane, the Jason membrane, which actually has a resorption time of 4 to 6 months versus a non-cross-linked collagen membrane, maybe a little bit shorter, things like that. So it all has to do with what my vision is for the final product.
Thank you. Thank you very much. There is another question that is similar because it's what kind of graft does you prefer, allograft or xenograft, or maybe you mix it?
I've done that too. I've actually mixed the two, particularly for some of my horizontal augmentation, because I want that scaffolding effect a little bit longer. But right now I'm using the Min-D-Min 70-30, 80-20. Like I said in the presentation, Borg and Mealy showed us that you didn't get any additional resorption, but you actually had greater bone growth using the demineralized, mixing the demineralized. Back in the one case that I showed you that I did back in 2008 or so, I was only using mineralized freeze-dried bone. But now all my cases are the LifeNet products, which have a Min-D-Min, which is a mixture of Min and D-Min.
And do you think that using allograft biomaterial could lead to faster time to insertion implant in staged approach?
Well, it depends on your definition of faster. In a stage, I'd say the bottom line is there's a few things I don't rush, and one of them is bone growth. So I typically will wait, 3 to 4 months for the complete regenerative process of the site development. So the bottom line is honestly, I don't rush. I even know, even with my implants, using the hydrophilic implants, you can actually rush a lot of it also, if you really think about it, has to do with soft tissue maturation also, which doesn't go any quicker than it does. So, you want your soft tissue to be mature before you restore your implants also. So, and particularly in aesthetic sites, I might even be doing some sort of augmentation, soft tissue augmentation afterwards. So the answer is I don't rush anything. The short answer.
I totally agree with you. I always say that since I'm Italian, when I am preparing pizza, I have to wait the right time for the dough to rise. And the same thing is with the soft tissue. So I totally agree with you.
Brilliant analogy.
But something that I think we need to give our audience as a decision-making process, because when we extract an hopeless tooth and we have to decide if we want to go through a delayed approach or to an immediate implant placement, we have to take into account different aspects. And there are a lot of questions regarding the lack of the buccal bony wall and the presence of gingival recession at the level of the tooth that you are going to extract. Do you think that these two anatomical conditions represent a contraindication for immediate implant placement, or you can in some way overcome this unfavorable condition? And
soft tissue you can't overcome. Okay, you really can't overcome that. I typically will, like I showed in the one case where we had the significant recession, I will always do that as a delayed approach. And then the question becomes, can we place the implant simultaneously after we've regenerated some keratinized tissue? So the short answer to that is, if I can place the implant in a restoratively driven position, I have good initial stability, and I am confident that I can regenerate that buccal plate I will go ahead and do that part as a simultaneous approach. But if I'm not confident, you know, I know a lot. I've also done several allograft rings, bone rings. I think that's you know, is gaining popularity in Europe as well, and it's gaining popularity in the United States as well. That I've seen people being extremely successful using that as a process of regenerating bone as well. But the bottom line is, for me, it's a confidence level. And if I see the site that I showed you in that type 2 situation where I was able to place it simultaneously, that was completely stable implant. It was a completely stable graft. And I had a lot of confidence that it was going to work.
And another thing that I really liked in your presentation was the use of the guided implant placement. And I think that especially in cases of immediate implant placement is something that should be strongly recommended in order to reduce the risk of buccal implant positioning that represent the let's say main predisposing factor to peri-implant soft tissue lesions occurrence in the aesthetic area. And do you agree with me? And do you think that?
I do. I do, and it all has to do with your preoperative preparation and studying the case. All these cases that I showed were well planned. You know, it's one of those things where, again, I don't rush anything. I don't rush any aspect of it, nor will I rush my treatment planning of the case. And yes, I do agree. And above all, restoratively driven. I work very closely with laboratory technicians, obviously my restorative doctors as well, in preparation for these types of more complex cases.
And there are also many questions regarding the use of zirconium material instead of titanium.
Well, no, these aren't ceramic implants. These are a titanium zirconium alloy, and this is the rock solid implant that Straumann is. I think it's been around since 2007, if I'm not mistaken. And it's the only material that's actually specifically designed for implant placement. In other words, they designed this material specifically for implant placement. And obviously the surface technologies are important in it as well. These are not ceramic implants. These are a titanium zirconium alloy. The alloy is actually stronger, so you can even consider using 3.3s very confidently and not have to worry about, because of its superior tensile strength, and you know, fracture isn't as big an issue with it. I should probably clarify that.
Yes, thank you. I think last question, because we don't have any more time, even if I'm sorry, because there are so many questions that we are not going to answer, but this is the time. What is the post-surgical regimen after the use of xenograft and membrane? When did you remove the suture? And do you suggest any specific rinsing instruction, adjunctive antibiotics?
Yeah, in the US, yes, there's no question we give our patients antibiotics afterwards. I feel pretty strongly about that. And we'll either give amoxicillin or clindamycin or cephalosporin. Those are the three our go-to quote unquote antibiotics, depending on the patient's sensitivities and allergies. I will typically use a mild chromic gut if I'm concerned. If I'm concerned about the tissue opening, depending on, sometimes I use a non-resorbable, which I'll keep in for as much as, you know, polypropylene, which I'll keep it if I'm doing some sort of mattress suturing. I would want to keep those sutures in a little bit longer. I would use something that's non-resorbable. I typically see my patients anywhere from 4 to 7 to 10 days post-operatively. Then I'll see them at the 2-week mark, and depending if necessary, I will see them more frequently as well.
Thank you very much. I think that your lecture and the answer to the questions was something really amazing. And now I have to call on the stage the next speaker, and I thank you very much.
My pleasure.
Hope to see you soon in person.
I look forward to it. Thank you, Martina.
Bye.
Bye-bye.
And now it's time to speak about the decision-making tree for gap management in immediate protocols. And Dr. Scheinitz, he will forgive me for the pronunciation of his last name, but it's so difficult for me. And he is head of the Division of Implantology at the Department of Oral and Maxillofacial Surgery at University of Mainz in Germany. He is an ITI fellow. He is the member of the National Osteology Group in German. And he is an active member of the German Society of Implant and Periodontology. And so it's really a great honor for me today to share the podium with Dr. Scheinitz. And please, the stage is yours.
Dear colleagues all around the globe, it's an enormous privilege and honor to be part of this amazing global biomaterials symposium. We already heard wonderful lectures from Dr. Miller and Dr. Wohlfahrt. The next topic is decision-making tree for gap management in immediate protocols. So we will talk about immediacy and biomaterials, a very, very hot topic, and I'm looking very forward to discuss this hot topic with you. So let's turn up the energy and start a hot 20-minute sprint through immediacy and biomaterials. How do we want to structure this lecture? First, we have to answer the question, when do we perform immediate implant placement? Do we perform immediate implant placement after every tooth extraction? Or are there specific indications? And when we have answered these questions, I want to show you why we use in immediacy a collagenated bone substitute material. So let's start with the implant placement protocols post-extraction. So as you all know, we have the immediate implant placement. So we pull out our tooth and do the implant placement at the same day. Then we have the early implant placement. And according to the ITI Foundation, we have the early implant placement of the early type after 4 to 8 weeks after tooth extraction, and of the late type 12 to 16 weeks after tooth extraction. In these cases, we have a full soft tissue healing and a partial bone healing. On the other side, we have the late implant placement. According to the ITI, implant placement after 6 months after tooth extraction. In these cases, we have full soft tissue healing and full hard tissue healing. In which cases now we do perform immediate implant placement. And we strongly recommend to do immediate implant placement if you have sufficient local conditions. What are these sufficient local conditions? If you have, according to the hard tissues, a fully intact facial bone wall with a thick fold phenotype of at least 1 millimeter remaining facial bone plate. And in respect to the soft tissues, you should have stable soft tissues, so a thick gingival biotape with no recessions. And of course, there should not be an acute purulent infection. If you don't have these local characteristics in your alveoli, or if you have a systemic risk factor, like the patient has a diabetes or the patient receives bisphosphonates, then you should not go for immediate implant placement, go for early or late implant placement. Which biomaterial now do we use in these different indications? For immediate implant placement, we fill this gap between our dental implant and the remaining facial bone plate with a collagenated bone substitute material. If we do early implant placement, so if we do our implant after soft tissue healing and partial bone healing, we don't do a normal average preservation. We just put in a collagenated sponge or a platelet-rich fibrin in our alveole to improve soft tissue healing. If we go for a late implant placement, we recommend to do an alveole-rich preservation with a xenogenic bone substitute or a collagenated bone substitute material to preserve the volume of your ridge. So we have discussed the different protocols. Now, if we have the indication for an immediate implant placement, we normally fill our gap between the implant and the facial bone plate with a collagenated bone substitute. Why? I will show you in the next 3 clinical cases. Here is Friedrich. Friedrich is a very nice 36-year-old man who has a tooth 16, who is unfortunately not worth preserving. In the cone beam, you see that this tooth is a very challenging one to go for immediacy because you don't have enough bone apical to your tooth of the root to get a sufficient primary stability. So in this case, you only achieve your primary stability here from the distal part of your dental implant. Here you see the situation after tooth extraction. And we check, is this a case for immediacy? We have stable soft tissues, no recession, we have no acute purulent infection, and we have a sufficient thickness of our hard tissues of at least 1 millimeter remaining facial bone plate. So you saw already in the slide before that we did a fully digital workflow with Straumann Smile in a box. So we here inserted our fully guided drilling template and do our first fully guided drilling. And we perform fully guided implant insertion. And here you see our BLX implant only receives its primary stability here at the distal part of the implant. So this is not a sufficient primary stability to go for immediate loading. Normally, we go in immediacy concepts for immediate loading, but in this case, we didn't have enough primary stability to put there an immediate crown on this dental implant. It was too risky for us. So we filled the gap between our dental implant and the facial and palatal bone with a collagenated bone substitute. And the nice thing with this collagenated bone substitute, it's very easy in the handling. So your particles stay there where you want them to stay. Then we fill this bone substitute in our implant with a collagen membrane, in this case a Jase membrane. It's a long stable collagen membrane. Put some sutures on top, and then after 4 weeks we already have wonderful soft tissues around our dental implant. In these cases we wait around 12 weeks for bone healing, then we go into second surgery to put an abutment on our dental implant. And here you see the wonderful emergence profile after healing, after second surgery. And here you see the final crown with very wonderful, thick, keratinized, fixed mucosa around our BLX implant and a very stable peri-implant bone after 1 year of follow-up. So again, in this case, we did an immediate implant placement, but not an immediate loading due to the missing primary stability of our immediate inserted dental implant. Let's go for the next case, immediate implant placement and immediate loading. This is a very wonderful patient and a very nice woman. She came to our department due to a fracture of her jaw. Here you see the fracture of the parasymphysis and of the condyle. She also had a longitudinal fracture, as you see in the next slides, of tooth 14 and 15. Due to this fracture of the condyle, we had to wait for 6 weeks to get a stable condyle. Then we can go for these tooth. Here you see the longitudinal fractures of these tooth 14 and 15. And these trauma cases are excellent cases to go for immediacy. So if you want to start into immediacy concept, take these trauma cases. You normally don't have an acute purulent infection. You have sufficient soft and hard tissues. Again, we do our planning with the digital workflow with Straumann Smile in a Box. So we did a cone beam, an intraoral scan, and matched these both together and did our digital planning and a fully guided drilling template, and CAD/CAM provisionals were produced pre-operatively. This tooth extraction got me some gray hair because the mouth opening of the patient was still limited due to the fracture, but these trauma cases, I already said it, are wonderful cases for immediacy. You see these very stable facial bone plate and these sufficient soft tissues around the alveoli. Now let's jump into the surgery. Here you see the fully guided drilling in region 14 and the fully guided drilling in region 15. And in these cases of immediacy, we strongly recommend to do under drilling. So only take the first 2 drills and then insert your dental implant to get a sufficient primary stability. Here you see the fully guided insertion of our BLX implant. And this is very wonderful in this fully guided digital workflow. Then you see the filling of the gap with our collagenated bone substitute. You see the easy handling, and I'm a passionate surgeon, but this is prosthodontist. Even I can achieve just screwing in the prefabricated crown. And it's amazing if you do a sufficient planning how well these prefabricated provisionals are fitting. Here as you see again the clinical pictures of our implant. This is a perfect implant position, a slight palatal position. Here we have the gap, which we fill with our collagenated bone substitute. This gap we fill with our collagenated substitute too. Then the situation after insertion of our provisionals and the sufficient implant positioning in the post-operative X-ray. Here after removal of the sutures we have fine soft tissue conditions, and after 6 weeks of healing we have a wonderful emergence profile around our BLX implants. In these cases we wait around 12 weeks for delivering of our final prosthodontics. Here you see the final bridge and the smile of our patient after 1 year follow-up with fine conditions around our dental implants with sufficient soft and hard tissues. Let's jump into the last case, an immediate implant placement in the posterior jaw. Here you see Stefan, 62 years old, with a tooth 36 not worth preserving. Here you see the digital planning. In these cases of multi-rooted tooth, we don't go for a fully guided workflow because we want to check our alveoli after tooth extraction where we exactly put our dental implant, because you can put it in the mesial root, in the distal, or in the interradicular septum, as you see here on our planning. A very important thing is the gentle removement of your tooth. So take your time that you don't crash or hurt your facial bone plate. Then very important, cleaning of the alveoli. And now you see the implant or the first pilot drill. In this case, we took the interradicular septum and always check after every pilot drill your occlusion. This is very, very important, and your axis of your planned implant. Here you see the TLX. We were very lucky in Mainz to have this TLX already for more than 1 year. Here you see the insertion of our TLX implant. and you see the sufficient primary stability of our dental implant. Then you see our collagenated bone substitute, which we fill between the gap between the facial bone plate and our TLX implant. Here again, the position of our first pilot drill. There is no evidence if it's better to put it here in the mesial or distal root or in the interradicular septum. In this case, we choose the interradicular septum. Here you see the sufficient primary stability of our TLX implant, filling the gap with the xenoflex and soft tissue suturing. You see the sufficient position of our dental implant and this wonderful soft tissue healing after 4 weeks around our tissue level implant. And here after nearly 1 year, we have the chance to take a cone beam due to implant planning in the upper jaw. And here you see this wonderful bone, this wonderful vestibular bone around our TLX implant. And in these cases, if the patient does sufficient oral hygiene, this implant will last probably for a very long time. So let's wrap up our session. We discussed the different protocols. So we said if we want to go for immediacy, we want sufficient local soft and hard tissues and no acute purulent infection. If we don't have these sufficient local parameters, or if the patient has systemic risk factors like a diabetes or a non-compliance, we go for early or late implant placement. We discussed that in immediacy, we prefer to fill the gap between the implant and the facial bone plate with a collagenated bone substitute. If we go for early implant placement, we don't normally fill the alveole. If we go for late implant placement, we do the alveolar ridge preservation with a collagenated bone substitute and a collagen membrane. Why do we use a collagenated bone substitute material like Xenoflex? Because this composite material with the bovine material and 10% collagen is ideal graft material characteristic for placement between the implant and facial plate. It's pliable and moldable but stable. And after hydration of your collagenated bone substitute, the substitute changes to a slightly spongy consistency, which enables you for an ease of handling. And of course, this bone substitute has a slow resorption rate, and so you have a long-term stability of your bone substitute around your dental implant, so that you can achieve long-term aesthetic and functional results. Dear colleagues, this was a very fast 20-minute sprint through the decision-making tree for gap management immediate protocols. Thank you very much for your attention. Now, of course, I would be very happy to discuss this protocol or the clinical cases with you. So if you have questions, please, I'm looking very forward for them. All the best for you from Mainz, and let's discuss these protocols and the clinical cases.
So thank you, Dr. Schneider. Can you please tell me how I have to pronounce your last name?
It's Stignitz. It's not so difficult, but just call me Ike. We are great colleagues.
Sorry for my Italian accent.
No, it's a very difficult name. No problem.
So we have a lot of questions also for you. I think that this afternoon we had an amazing global symposium with a lot of people and a very active audience. I start with the first one. For immediate placement, when feasible, and to achieve optimal primary stability, which insertion torque is minimum necessary in your opinion, in both aesthetic zone and regardless of guided bone regeneration?
Yeah, wonderful question. Thank you for that. Yeah, we normally take the insertion torque. So we just look at our machine, or if we do it with the hand, we could look at our insertion instrument, and we want a primary stability of at least 30 Newton centimeters. I know there are colleagues who do it with the ICQ values.
So they want an ICQ value of at least 60. And there are colleagues who take a combination of insertion torque and ICQ values. So they want an insertion torque of at least 30 Newton centimeters and an ICQ value of at least 60s. And I think it's does not depend on it's in the aesthetic area or the non-aesthetic area. So in our clinic in Mainz, we want an insertion torque of at least 30 Newton centimeters to go for immediate loading. In the first case I have showed, we only had around 10 to 15 Newton centimeters. That was the reason why we were conservative and went for a delayed approach, because we didn't reach these 30 Newton centimeters.
There is one question regarding the guided approach. And I think that this is a really important take-home message that we should give to our audience. How confident would you feel to do immediate implant placement and immediate loading without using a guided approach?
Yeah, a wonderful question. If we look at these disaster cases, where nothing worked well, the patient is unhappy, we have an aesthetic or functional bad outcome. The problem is mostly facial malpositioning of our implant. So one of the most important thing is to place your implant a little more to the palatal side, not to the facial side, because then it becomes a disaster case. So every tool we use to get a positioning of our implant is a good tool. And I think guided surgery is a wonderful tool to think more prosthetically. I'm a surgeon. I want to see bone, I want to see tissues, but as a surgeon, it's very important to think before you act. And this guided surgery helps to visualize your patient. You create a virtual patient. And so you sit on your laptop and have a look there. It makes sense to put my implant, and there I'm in the comfort zone, so that I have a distance between my bony envelope and my implant shoulder. So I think this guided surgery is very important, not to create this facial malpositioning, but it's only a tool. It should not be the goal to go for guided. It's a tool. So don't be a machine and does it like a monkey. Just put in your drilling guide and just do the drilling. That's not the right thing. You still have to think. So after every pilot drill, if guided or not, take a positioning pin and look if you are in the right axis in all 3 dimensions. And I think you have to get feedback from the patient. So move the jaw and look if you're in all axes well. So I think that's the important thing. It's a very good tool to be more prosthetically, but it's not, you still have to use your brain. So the combination of brain guided and fully guided, I think it's a perfect combination to get the best out of for our patients.
Yes, thank you very much. I totally agree with you. I think that guided and brain implant placement is the key for the success in terms of function and aesthetics, and also because to learn how to make the right planification is something that requires a learning curve. So especially at the beginning, you don't have to trust 100% in your planification, but as you told, and I totally agree, you need to check if the planification have been done properly. Yeah, obviously, then when you become more familiar with the planification system and the guided system, you can be more confident on that. But especially at the beginning, it requires a learning curve.
Absolutely, absolutely. And I think it's the technical stuff to match your DICOM files with the intraoral scan files, and it takes very much time. So I think at the beginning, you can get a good technician who does this job for you, this matching stuff. Yeah. But the implant planning you should do on yourself. Don't delegate this implant planning to someone else. You can delegate the matching. Everything is fine. It takes a lot of time at the beginning. So let's do someone else. But the positioning of your implant, you are responsible for it. Do it on your own. And then, of course, guided surgery still is something to do. So you have to be a good conventional surgeon. So just skipping to learn conventional surgery and go right away to guided surgery, that's not the right way. Because if your guide doesn't fit or the guide breaks, you're suddenly alone.
To solve the problem.
Before going to fully guided surgery, be a good conventional surgeon in the non-aesthetic area. And if you're familiar with your implant system, with your primary stability of your implant, if you know how to do under drilling and stuff like this, then you are ready to go for guided surgery and to get the best out of the system.
Thank you. Thank you very much. One more question. May it happen that the bone might grow on top of the implant if you don't load it, obviously? And in case, what are you going to do?
Yeah, absolutely. It is possible. If we look at Professor Buser, he always positioned his implant slightly subcrestal and put an abutment inside with a height of 0.5 millimeters or 1 millimeter and puts his bone substitute above the implant. So there is the bone substitute normally growing over the implant, but it's no grabbing. There are drills. You can just get a drill from your manufacturer. So this bone is easy to take away and not to hurt your implant surface. So I think it's something great if the bone grows over your implant, so you know everything went well, and to put away this bone, it's no problem.
If the jump gap is less than 2 millimeters, should we go for bone graft? And when you apply a bone graft in the jump gap, is required to be covered by a collagen membrane or not?
Wonderful question. This small jumping gap, I fill with the bone substitute out of a feeling, because I want to have something in this gap, but there is no evidence that it's really necessary. So I can't get you a RCT who shows that it's better to fill something in. It's a gut feeling, but there is no evidence behind. A membrane, you don't know. It's a semi-open healing, you can say, because if you put your provisional on top of your implant, it's like a membrane. So we don't put a membrane in, because if you want to put a membrane, you have to do a flap, and this hurts the periosteum. So we do flapless surgery in these immediate implant placements. So we don't use a membrane because we don't want to hurt our periosteum, and it's not necessary because you have your provisional on top of your implant.
Thank you very much. And can the bone substitute be in contact with the temporary crown, or do we need an intermediate membrane?
Yeah.
And another question regarding the temporary crown is, it after immediate implant placement, you deliver a final restoration that is final or temporary? So
yeah, wonderful question. We are thinking about putting the final prosthodontics or the final crown in, because our implants are so primary stable with this new implant design, BLX, TLX, or from the other manufacturers too. I think the primary stability is high enough to put your final crown on the implant, but there is no evidence in the literature. So at the moment, we all put a provisional on top. But I think the future is that we put the final crown on it, so it's not so expensive for the patient. But at the moment, state of the art is to put a provisional on it, and we do it in Mainz too. But we are thinking about the study to put the final crown on it, yes.
Yes, but on the other side, I think that maybe the use of the provisional restoration is needed when you have to perform a soft tissue conditioning. If you have an implant placement with a simultaneous mucogingival procedure to increase the soft tissue thickness or whatever, I think that you need also to condition this soft tissue with the provisional crown. So maybe we will have to find some indication for the use of a final definitive restoration and for the use of a provisional one, in this case of combined soft tissue and hard tissue augmentation procedure. What do you think about it?
Yeah, absolutely. That's the reason. And because that's the reason why we still put a provisional on it, to form our emergence profile. And it's a little more conservative. To put the final crown on it, it's, yeah, there is no evidence in it, so I wouldn't do it at the moment. There have to be clinical study who prove that this concept could work, but not at the moment.
And should we make our immediate loading prosthetic restoration always out of occlusion? So it's immediate loading, but it's not in occlusion?
Yeah, we check the occlusion. We are honest. We try to get them out of it to minimize the risk, because we don't want an implant failure. And if it's in occlusion, there is a higher risk to lose your implant. So we really check for occlusion that the implant is, or the provisional is out of occlusion. I think it's really necessary.
Last question for you is, what is your opinion about short implant and immediate loading?
Oh, we are doing it in Mainz, but I have to say that the evidence is very low. So we have to discuss what is really short. In former times, an 8mm implant was short, but I think there is consensus now that the short implant is everything equal or less to 6mm. So these 6mm implants with the modern designs, you get a primary stability easily of about above 30 Newton centimeters. It's no problem. They are small marbles. You never think that they get stable, but it's amazing how primary stable are these short 6mm marbles. But there is no real evidence in the literature, so high-class publications who show that it's possible to load these 6mm implants or even these 4mm implants immediately. So I would be conservative not to recommend this procedure, but I can tell we do it from time to time, but it's not a thing we do every time with these short implants. It's only in a patient where it's a single tooth gap, and if we know that it's not heavy occlusion on it. So it's not that 200 kilo man who's biting like a really strong man. That's a contraindication for us to immediately load short implants.
Thank you. Thank you very much for answering this question. Now I have to say you ciao, and
ciao.
Hope to see you soon in person. And now it's time for the next and for the last speaker of the afternoon. Bye.
Martina, thank you very much. You are great. Thank you.
Thank you. So now we have on the stage Dr. Eric Regidor from Spain, and he is going to speak about the decision-making treatment for the treatment of peri-implantitis. So now we are starting to solve the problem. We already know everything about immediate implant placement, how to fill the gap, how to manage the socket, how to save teeth with periodontitis before extract them and place an implant. Now we are going to learn how to manage peri-implantitis. Dr. Regidor is a specialist in periodontology and dental implant, and he is master in science, and he is assistant professor and clinical researcher at the Thinking Perio Research. So now the stage is yours, Dr. Regidor, and looking forward many questions from our active audience.
Dear friends, dear colleagues, my name is Eric Regidor. I am a specialist in periodontics and implant surgery in Periocentrum Bilbao in Spain and researcher for Thinking Perio Research Group. First of all, I would like to thank to Stroman for the kind invitation to lecture here in this excellent Stroman Biomaterials Global Symposium about the decision-making tree for peri-implant therapy. During the next presentation, I would like to explain to you our daily protocol in the treatment of peri-implant disease and the key factors in peri-implant therapy according to the literature. The first key factor that I would like to mention is the diagnosis and the prevention of peri-implant disease. When a patient presents a combination of inflammation of the peri-implant mucosa and loss of supporting bone, we have to think about that we are in front of a patient with peri-implantitis. Regarding to the prevalence in countries like Spain, it is rated to be around 22% of the subjects suffering from peri-implantitis. Therefore, this high prevalence shows us the importance of identifying any possible risk factor in each patient in order to reduce the risk of developing a peri-implant disease. The next crucial aspect that I would like to mention is the peri-implant defect configuration. When we analyze the scientific literature describing the different defect configuration around implants, we can find a supra-bony defect configuration or a intra-bony defect configuration, and also a combination of supra-bony and intra-bony component in the same peri-implant defect. According to the scientific literature, when we face a supra-bony defect configuration, our approach should be a resective surgical therapy, and on the other hand, when we face a intra-bony defect configuration around an implant with peri-implantitis, our approach should be a reconstructive surgical therapy. Chronologically, the next key factor that I would like to highlight is the implant surface decontamination and what we know actually about different implant surface decontamination methods and tools. According to Louropoulos and co-workers articles, the ideal decontamination method should not only remove effectively the attached biofilm and calculus from the implant surface, also must avoid any significant deleterious changes or damage at the implant surface. Actually, we have several implant surface decontamination methods that have demonstrated to be clinically effective on removing attached biofilm and calculus from the implant surface, but we have to take into account that all of them cause minor to major topographic changes in the implant surface. It is therefore emerging literature proposing this type of labrida chitosan brush to decontaminate the implant surface in order to be effective on removing the calculus from the implant surface, but also demonstrating a more friendly behavior with the implant surface. Moving on to the next key factor, we must focus on the peri-implant hard tissues and biomaterials that can be used in the surgical treatment of peri-implant related intra-bony defect. 2 years ago, we had the great honor to participate in this systematic review with the University of Gothenburg, assessing the changes in clinical and radiographic parameters after performing a reconstructive surgical therapy of peri-implant related intra-bony defect, but the outcomes must be interpreted with caution because of the heterogeneity between the studies and the different bone grafts. Nevertheless, we concluded that the xenogenic bone graft is the most used graft till date. Let me share with you this clinical case that we have seen previously in this presentation. You will remember that we raised a full thickness slab and we performed the implant surface decontamination with this labrida chitosan brush. After the implant surface decontamination, we used a xenogenic bone graft in order to fill the intra-bony component of the peri-implant defect. This was the situation clinically and radiographically when we finished the surgical procedure, and those are the outcomes at 1 year follow-up. So probably the question at this point is if we have successful outcomes only using a xenogenic bone graft, what is the rationale for using a resorbable membrane? According to this case series from Alberto Monge and co-workers, they reported successful outcomes in terms of clinical and radiographic parameters when they used a xenogenic bone graft filling the intrabony component of the peri-implant defect and a resorbable collagen membrane covering this bone graft. So in this type of clinical situation where we have an intrabony defect, but also we have lost the buccal plate or the buccal aspect of the bone plate, we must consider the option of using a xenogenic bone graft in order to fill the intrabony component, but also a collagen membrane in order to cover this bone graft and to reconstruct this buccal bone plate. Look at this clinical case where we perform the surgical treatment of the peri-implant defect using simultaneously a xenogenic bone graft and a resorbable collagen membrane, and we not only achieve the reestablishment of peri-implant health and the radiographic bone fill on the mesial and on the distal aspect, we also achieve the reconstruction or the thickening of the buccal aspect of the implant. So in this point, we must ask again if there is any additional biomaterial that could improve our outcomes in the treatment of peri-implant related intrabony defects. In 2018, Mercado and co-workers published this randomized clinical trial proposing the additional use of enamel matrix proteins due to their biological properties. Furthermore, we are actually investigating about the additional use of enamel matrix proteins in the treatment of peri-implant related intrabony defects. We are comparing the use of xenogenic bone graft and a resorbable collagen membrane in the control group over the additional use of enamel matrix proteins in the test group. Let me share with you the surgical procedure of one of the patients included in the study. We raised a full thickness flap, and after the debridement of the granulation tissue, we use the intraoral scan in order to assess with better accuracy the intrabony defect configuration. Later, we perform the implant surface decontamination with mechanical methods like Labrida chitosan and with chemical decontamination methods. Then we apply the enamel matrix proteins over the implant surface, and then we use this xenogenic bone graft in order to fill the intrabony component of the peri-implant defect and in order to reconstruct the absence of the buccal bone plate. Finally, we use this customized collagen membrane, fixing it with the prosthodontic abutment at the implant, and this is the clinical aspect on the occlusal view, and this is the primary wound closure of the surgical procedure clinically and radiographically with the filling of the defect around the implant. Regarding to the next key factor or relevant aspect in the treatment of peri-implant disease, we must mention the importance of the peri-implant soft tissue. According to this narrative review from Jan Benstrom and Jan Derks in 2012, the absence of keratinized mucosa is associated with a higher risk of soft tissue recession, with a lower vestibulum depth, with higher plaque and bleeding improving indices, with higher brushing discomfort reported by patient and also with higher risk of suffering changes in bone level assessed radiographically. Therefore, in this type of clinical situation, we must consider to prevent patients from suffering from peri-implant disease or from biological complication around the implants, and we must consider the rationale for performing soft tissue grafting around implants in order to increase the quality and the quantity of soft tissues around the implants and to increase the width and the thickness of the peri-implant mucosa. Autologous connective tissue graft has been historically considered the gold standard in soft tissue therapy around teeth and also around implants. Nevertheless, when we harvest a soft tissue graft from the palate of the patient, we must consider the risk of some disadvantages, like higher surgical chair time, higher postoperatory morbidity associated also with a higher analgesic consumption, and limited availability from the palate of the patient. To overcome this problem, there is emerging literature proposing the use of soft tissue substitutes like this type of xenogenic collagen matrix that can be used both at the same time of implant placement and also in the treatment of peri-implantitis in order to increase the width and the thickness of peri-implant mucosa surrounding our implants. The last key factor that I would like to highlight is the relevance of supportive periodontal and peri-implant therapy. Let me introduce you this concept by the presentation of this clinical case where we performed some years ago the reconstructive therapy of several intraponic defects by the use of this xenogenic bone graft and a resorbable collagen membrane covering this bone graft, and during 7 years the patient did not return to supportive periodontal therapy, and finally we lost all the implants. This supportive periodontal and peri-implant therapy can be performed by the use of this type of Labrida chitosan brush again in order to decontaminate effectively the implant surface without causing any damage at the implant surface features. Finally, I would like to thank to all the Periocentrum Bilbao team for their daily support, that it is really appreciated, and especially to my mentor and friend Alberto Ortiz Bigon. If the audience have any question, I will be happy to answer it, but here you have my email and my social media, and you can feel free to contact me. Thank you for your kind attention.
Thank you, Dr. Regidor, for your amazing presentation. And we have a lot of questions also for you. And so ready for the questions?
Yeah.
Okay, so excellent cases. Thank you is one of the colleague at home. And he asked us, how do you detect early peri-implantitis? And I think that this question is really a great question, because we need to understand when it is possible to treat a peri-implantitis defect or when it is not possible, in order to decide when extract the implant or when try to solve the defect with a surgical procedure as you show. Which are your, let's say, decision-making process on this decision?
Yeah, it's a very good question, yeah, Martina, because I think that probably one of the most important factor in this situation is the diagnosis and the difference between peri-implant health, mucositis, and peri-implantitis. I think that using the paper from Frank Sparks and co-workers, about the diagnosis on peri-implantitis, I think that probably the best option in order to a good diagnosis of peri-implant disease is recording the peri-implant parameters in the baseline situation. I think that this baseline situation must be when we perform the implant supported reconstruction. I think that in this situation, we must record the peri-implant pocket depths, the absence or the presence of bleeding improving, and also a baseline periapical X-ray. No? I think that probably when we are going, I am speaking now about implant that we have placed. No? When we are comparing this situation in the future, when we find a peri-implant bone defect or probably an augmented peri-implant pocket depth, we have to compare with the baseline situation in order to understand what is happening around this implant and in order to take a decision about if there is peri-implant health, because the situation is the same as baseline, or there is a progression of the pathological situation, and we can speak about mucositis or peri-implantitis. No? This is probably the most favorable situation to the diagnosis. And well, because of the time of the presentation, we did not consider the situation of when we have to extract an implant, no? But I think that we only have two situations in order to treat surgically, at least, that are resective approach of regenerative, or probably most better said reconstructed approach. No, I think that in this type of situation, we must consider also patient reported outcomes in order to patient perception about the treatment, the aesthetic situation, because it is not the same situation where we are going to treat an upper incisor or a lower molar. No, probably the best, the most indicated situation in order to extract an implant or in order to remove an implant, I think that the most complicated situation to treat is three-dimensionally inadequate position of the implant. No? I think that this type of situation where the implant is too backally placed, I think that in this type of situation probably we must consider the option of removing the implant and to start again with guided bone regeneration and probably a new implant. No? The other situation that is, we can discuss about it, but I think that when we have an horizontal defect around the implant in the aesthetic area, I think that in this type of situation, we must consider that when we perform a surgical approach, we can get successful outcomes in order to, or in terms of peri-implant parameters, but we must consider again the patient-reported outcomes. We can find a situation with a peri-implant health, but with an aesthetic problem. And in this type of situation, we must take into account the probably we must avoid the situation with buccal soft tissue dehiscence. In this type of situation, we must consider also that the removing of the implant is a good choice.
Thank you. Thank you very much for your exhaustive answer. But I have a lot of other questions.
Okay.
I have a lot of questions regarding the use of endogens. For example, would you recommend the use of Flapless endogen for the treatment of mucositis, for example? And when do you use endogen intrasurgically? Do you also apply EDTA to decontaminate the implant surface?
Yeah, but at first in mucositis situation, I think that probably the biological properties of the enamel matrix proteins about the mucosal healing, I think that in this type of situation where we are going to treat to diminish the inflammation around the implant, I think that in this type of situation, I think that we must consider this type of enamel matrix proteins simultaneously to other implant surface decontamination methods like Labrida cytosembras. No? On the other hand, I think that we must consider another terms, not only peri-implant parameters. We must consider the cost and the benefit about using this type of enamel matrix proteins in the mucositis treatment, because we have to convince the patient to perform this non-surgical treatment of the mucositis. But in very inflammation situation, I think that it would be a good choice. Nevertheless, there is not too much evidence about this recommendation. When we talk about the use of enamel matrix proteins in the surgical treatment of peri-implantitis, I think that probably the scientific literature about this topic, about different bone grafts or collagen membranes around implants in order to reconstruct the bone defects around implant, I think that probably the most favorable situation is a crater around the implant, where we have all the walls around the implant, and in this type of situation, probably the best choice is only a bone graft. When we have lost the buccal aspect of the implant, I think that in this situation, and taking into account there is no too much evidence about the use of collagen membrane in peri-implantitis, there are no too many difference about using or not a collagen membrane, but I think that taking into account different systematic reviews about guided bone regeneration when we place the implant, when we take into account these outcomes, the outcomes that we can achieve when we use simultaneously a bone graft and a collagen membrane, and the membrane is not exposing, I think that these outcomes are better than when we use only a bone graft. Regarding to the enamel matrix proteins in this type of situation, and what is the additional outcome about using this, I think that we have to take into account three situations or three advantages. The first, you have mentioned about it, is the previous use of EDTA. In this type of situation, we are performing in our study mechanical decontamination of the implant surface with the Labrida cytosembras, but we have to take into account that when we use the enamel matrix proteins, we are using previously this mechanical decontamination that will improve the implant surface decontamination in the same procedure. No? This is the first advantage. Probably the second advantage is the immediate advantage is the wound healing that improves when we use the enamel matrix proteins. And probably the third advantage is that there is not too much literature about the use of this type of enamel matrix proteins in peri-implant disease. Only probably this randomized clinical trial of Mercado and co-workers, but we have to think about that there is a lot of indication of these enamel matrix proteins in periodontal regeneration, and probably the conclusion is that the enamel matrix proteins promote the new bone formation in around teeth, and also we can suppose it around implant. And I think that in this more challenging situation, I think that probably is a good choice.
I cannot hear him.
Thank you.
Okay, now I couldn't hear you anymore,
okay,
so
okay.
sorry. So thank you very much for your lecture and for the your answers. I think now it's time to close this amazing global symposium. I'm really honored to have been part of this afternoon. Within among all of you, all 4 speakers gave us a lot of insight into different topics, and I think that we learn a lot, and we learn how to manage with the biomaterial. We learn novel perspective on the use of biomaterial, for example, in non-surgical treatment of periodontitis and in the surgical treatment of peri-implantitis. We discuss a lot about the socket management and about the immediate implant placement, discussing about the use of different biomaterials, indication, contraindication. I think that this afternoon was a really fruitful afternoon for all of us. So I thank you very much, Straumann, for this invitation and for having organized such an amazing group of speakers. And I want to say goodbye to all of you, dear colleagues all over the world. Hope to see you soon in person, and have a great evening. Bye.